Today, an update on complications of laparoscopic myomectomy is the title of the talk. And maybe next slide, yeah. He is consultant obstetrician and gynecologist, Tom Clinic for Women, Thompson Medical Center, and also senior consultant, minimally invasive surgical unit division, KK Hospital, very famous hospital, yes. And visiting consultant OBGY, Singapore General Hospital, and chairman, Singapore OG Group. And his training is in minimal invasive surgery in 1996. Professor Kenneth Hatch, Department of OBGY, University of Arizona, USA, and also C.Y. Liu, Tennessee, and James Daniel, Nashville, USA, and President of OBGY Society of Singapore, 2007 through 2009. So I'm looking forward hearing an update of complications of laparoscopic myomectomy from Dr. Beh Suan Tiong.
Thank you very much. Thank you, Professor Tsutsumi. Thank you, Professor Lee, for the invitation. Wow, this is the time of the day in Singapore, the very famous view that some of you might have been there before, our iconic Merlion facing the Marina Bay Sands Integrated Resort. I hope to welcome you physically in Singapore soon. In case you want to know where is Professor Lee's office, there it is on top of the MBS.
Oh, please.
No, I'm just joking. All right. Okay, I'd like to thank also the organizing committee of APAGE-ISMIVS for the invitation to this webinar. And my topic today is on update on complications of laparoscopic myomectomy. This is where I practice, Thompson Medical Center, and I'm also a visiting faculty to the minimally invasive surgery unit in KK Hospital together with Professor Bernard Chen. Just a very brief introduction. I'm sure all of us witness increasing demand of myomectomy from our patients. The reasons are basically myoma is a disease that carries a huge disease load in the population. And despite the availability of many non-surgical options, surgery still remains a mainstay of treatment. The general delay in childbearing age increases the risk of fibroids in these women and the need for intervention as well. Myomectomy is increasing favored by patients, even for those without further fertility demand, as they long for organ preservation nowadays. And laparoscopic myomectomy, with its well-known benefits of being minimally invasive surgery, is very sought after by patients. Just to illustrate my point, comparing the 2 years of statistics from USA, 2011 to 2015, we can see the colored portion of the chart that myomectomy has increased together with the endoscopic approach, being hysteroscopic and laparoscopic myomectomy. It's estimated about 34 to 40,000 of myomectomies per year in USA. A similar trend can be observed in UK. My lecture today will divide into 3 portions. We shall just very briefly revisit the list of complications and spend a bit of time to identify the limitations and specific problems associated with this procedure, and at the same time to discuss the recommendations and solutions. I'm sure the list of adverse events or complications in this table is very familiar to all of us. It reflects the general complications that we can tell the patient for every laparoscopic procedures. However, we're more interested in those that is perhaps more specifically associated with laparoscopic myomectomy. And in the interest of time, I'm basically going to concentrate on 3 areas, namely hemorrhage, uterine rupture, and undiagnosed sarcoma. This is an estimated range of incidents, and just to further emphasize on what Professor Chen has mentioned earlier, adhesive disease following myomectomy is a very common problem. About 1/3 to 2/3 of patients will develop that. And this is especially important in patients with fertility requirement. We shall quickly move on to the next part of the talk, basically to identify the limitations and the problems. We all know that uterus is a very vascular organ. Fibroids can be huge, can be multiple, and yet laparoscopic suturing, no matter what, is still slower than open approach. It's important to repair the defects of the myometrium well after enucleation of the myoma to achieve 3 objectives, in fact. Number 1, to stop the bleeding effectively and quickly. Number 2, so that the myometrium can heal strongly and preferably without much adhesions. Failing to do so will, number 1, lead to uncontrolled hemorrhage. Serious hemorrhage during myomectomy commonly lead to laparoconversion. And of course, it depends on the experience of the surgeons and the center. And various reports has give a range of conversion to open myomectomy up to 17%. This is the higher end will probably be associated with centers that newly embark on laparoscopic procedures. Sometimes even lead to unplanned hysterectomy, ranging from 0.3 to 2.7%. And usually when this happens, especially in patients when there is still a demand for fertility, it will spell huge trouble. Some papers analyze the risk factors for intraoperative hemorrhage. And in this systemic review, it concludes that the size of fibroids does matter, especially when it's more than 6.5 centimeter onwards. The numbers when it's more than 3, and the location of fibroids being intramural compared to subserous. What are the tips that is available for us to utilize to help to reduce this problem? I think all of us realize that prophylactic hemostatic control is something very important in laparoscopic surgery. And this concept is even more so for myomectomy. Secondly, we do need to have precise and effective electrosurgical hemostasis for active bleeding vessels, while the diffuse widespread oozing in the myometrium should be managed by suturing. And good and quick layered repairs to arrest active bleeding and avoid hematoma formation, except for perhaps pedunculated fibroids. Let's just run through what are some of the strategies that can help to overcome this problem. I think many of us have the experience of using preoperative GnRH agonists. It is well known to be effective in decreasing vascularity and the size of the fibroid. It is not my favorite, however, because I always find that it makes the fibroid softer, make it more difficult for traction and morcellation. Smaller fibroids tend to kind of disappear, make it difficult, especially those that is intramural, to detect during the surgery, and that may, I feel, lead to higher chance of recurrence. And of course, we need to give it a couple of months before the operation to expect a shrinkage of about 30 to 50%. It is, however, useful for patient who is anemia because it helps to reduce the bleeding and allow time for the hemoglobin to build up. Ulipristal acetate or ASMIR, 5 mg daily, has also been shown to be able to produce similar effect. However, the drugs has been temporarily suspended due to its associated liver toxicity. This is an old paper published in 2009, a Cochrane review of all the strategies that is available to help to reduce hemorrhage during myomectomy. So these are the methods that they review. And there's a list of fantastic 5, I call it. Namely, these 5 agents seems to be the most effective. Pericervical tourniquet is the most effective of all, but however, its usage in laparoscopic surgery is probably quite limited. The next best thing will be the vasopressin, and in countries where this drug is available, I believe it's very commonly used because it does help a lot in reducing intraoperative bleeding and allow us to tackle fibroids that are huge and multiple. Some intraoperative techniques is also useful. Uterine artery occlusion as its origin is particularly useful when you're dealing with very big fibroids, as this can be very vascular. As you can see, this is a huge, this is a huge blood vessels, uterine vessels. However, this is a complicated procedure and should be only performed by experienced hands because by itself can lead to severe complications as well. Professor Prashant did mention about in his earlier lecture about the choice of uterine incisions, whether vertical or transverse. I concur with him that a horizontal incision is perhaps better. And if you look at the architecture of the uterine vasculature, it makes sense that a transverse parallel incisions to the vessels would reduce the number of blood vessels that you will sever when you cut through it. Remember, the second objective of the repair is to allow the tissue to heal strongly. Hence, we should avoid overzealous electrosurgery as this will lead to tissue necrosis and poor tissue healing. Effective suturing is also important, as insufficient layers of suturing or poor technique may actually lead to poor tissue apposition, lead to defective healing or hematoma formation. And this will lead to the next thorny problem that Professor Chen alluded to earlier on too, the issue of uterine rupture after myomectomy. It is rare, reported roughly to be from 0.6 to 1%, but disastrous. The problem is rather difficult to assess accurately and is likely underreported. Hence, we need to turn to some systemic review on this problem. In this article, published in 2014, the authors analyzed about 27 published articles of about 2,000 over myomectomy, a mixture of majority laparoscopic, some open, and some TCRM. And in this study, they reported 29 uterine ruptures that make an incidence of 0.7%. All but one occurred prior to the onset of labor. 80% happened between 28 to 36 weeks. It's a big range, all right, but 80% of them happen premature. There's a higher trend after laparoscopic myomectomy compared to open myomectomy. However, statistically, it is not significant. Yet another paper looking at the trial of labor after myomectomy and uterine rupture, published in 2016. Out of the 1,008 deliveries or so, there were 11 cases of uterine rupture, making an incidence of about 0.6%, 70% of which is after laparoscopic myomectomy, about 30% after open myomectomy. And again, majority are before 36 weeks. So it leads to a huge problem of prematurity and neonatal mortality. This is an unpublished series from KK Hospital. Thank you to Professor Chen for allowing me to share this data. This is during a study period of 12 years from 2003 to 2014. There were 50 cases of uterine rupture recorded, and making an incidence of 1 in 2,000 deliveries. Out of the 50 cases, 10% were associated with previous laparoscopic myomectomy. And they were all done in other hospitals, not in KK hospitals. And all these 10% again occurred antenatally and before the onset of labor. So what can we learn from all these studies? Number one, uterine rupture after myomectomy tend to happen before the onset of labor. It can happen as early as middle second trimester to early third trimester. Hence, a planned cesarean section should be earlier rather than later, perhaps once the baby reaches 36, 37 weeks. And interestingly, those that go through the antenatal period without much problem and enter labor spontaneously at term, the risk of rupture is similar to VBAC. Probably this represents the group of patients whose myometrium after myomectomy heal rather well. So to reduce the risk of rupture, again, I need to emphasize, avoid excessive electrosurgery, good and proper stitching, multiple layers is preferred. We know that laparoscopic suturing is more difficult. However, with appropriate practice, training, and experience, it can be comparable to laparotomy. If there's real difficulties to achieve this, surgeons are always able to enlist other forms of help if the resources permit. For example, you can resort to robotics, which is good to enable a surgeon who can't suture well to provide proper stitching. Or the use of barb sutures can also help to anchor and enable a better closures of the myometrium. However, I feel that for patients who desire future pregnancy, if there's any doubt on the quality of the repair, laparotomy is preferred. I think the tragic consequence of uterine rupture in the future pregnancy far outweighs the benefits of minimally invasive surgery. As I was doing literature search in preparation for this topic, however, I come across some interesting anecdotal evidence of repairing the ruptured womb when it happened as early as 21 weeks or 15 weeks. And as long as the baby was still okay at that time, despite the massive hemoperitoneum or the rupture, repair of the womb helped to actually delay the delivery of the baby up to about 10 to 12 weeks later. Hence, it brings a pre-viable fetus to a viable fetus. So this is something that you may want to consider if unfortunately there's such a case landed on your desk. Next, we need to look at the morcellation issues. Morcellations is an inherent part of laparoscopic myomectomy because we are essentially trying to remove a large firm tissue through a small hole. It's like this man squeezing through the rocks. So it's needed for any sizable fibroids, whether using power or non-power, abdominally or vaginally. Of course, it's not without its risk There may be inadvertent visible injuries, especially intestines. And leftover fibroid pieces can lead to parasitic fibroids or disseminated peritoneal leiomyomatosis. It's a unique sequelae due to mosylation, and the common locations tend to be at pouch of Douglas, mesentery, omentum, or in fact anywhere in the abdomen attaching itself to the parietal peritoneum. Like this patient, she has a parasitic fibroid growing just below the subdiaphragmatic area. This is the liver and that's the gallbladder. This is another patient, 45-year-old with previous leiomyomectomy for multiple fibroids, presented 7 years later with left iliac fossa painful mass. So an 8-centimeter parasitic fibroid was seen attaching to the left lateral wall at pelvic rim. So this is the fibroid. It was originally covered by the omentum and intestines. So after gentle separations, slowly after dissection, the fibroids emerge. This is the full view of the fibroid. It looks rather bizarre, in fact, and very vascular. And for a moment, I was quite worried, could there be any sarcomatous changes? And this is just to show the uterus, the fallopian tubes, and the ovaries somewhere there. So the fibroid originally occupied this entire area. So it is a good habit, number one, to count how many fibroids have we removed. Visually follow closely the picking up and mosylation of every fibroid. Meticulous removal of all the visible pieces. And mosylate as long a strip as possible, avoid pulling too hard, and have a good assistant to help you in this. And contain mosylation within the back may help to reduce this problem as well. The next topic that we like to discuss is actually the difficulty to differentiate sarcoma from leiomyoma. This is not a new problem that we face. Ever since myomectomy is performed, we know we may face this problem because it is simply very difficult to differentiate sarcoma from leiomyoma preoperatively. There's nothing reliable. However, the problem becomes sharpened and come into focus with laparoscopy and power mosylation. Of course, this whole issue was brought to the limelight by FDA's safety alert since 2014. I shall not go into that because I'm sure we are all very familiar. In the first place, the data that FDA quoted has been thought to be rather high, very contentious, and many organizations have come up with their own studies and own statistics. It's estimated, however, is still around 0.2% or so. Not only preoperatively, but intraoperatively, it is very difficult to differentiate. Which one do you think is fibroid? Which one do you think is sarcoma? We need to base on some parameters to help us to further that, to try to exclude sarcoma, although it's not very successful. We know that most of the time, sarcoma rarely happen before the age of 40. Of course, this is not foolproof. The clinical presentation is not really helpful. Patients with some risk factors, these are the common risk factors that is cited, but they are very rare stuff. Ultrasound features, MRI features are not exactly very predictive. There's been some tests on LDH isoenzyme 3 and supposed to help in the detection. And endometrial biopsy, right, has been thought to be able to help to diagnose sarcoma in 38 to 66%, especially in women with abnormal uterine bleeding. And the European Society of Gynecological Oncology advocates that as part of the workup for sarcoma, endometrial biopsy should be included. How useful is MRI? Well, it does offer some clue. There are some studies that mention that leiomyosarcoma does not form calcification. Presence of intralesional hemorrhage make it more suspicious. Similarly, for irregular margin. And in some situations, gadolinium contrast may help to improve further the detection rate. A few practical questions that I'd like to ask is, what is considered adequate evaluation of fibroid? Does every case require MRI, endometrial histology, LDH, etc.? How often are sarcomas missed actually? Especially, there are so many fibroids and many of them receive non-intervention or non-surgical intervention. There are anecdotal reports available, but there's no proper reporting registry. Is myomectomy or only myosimulation that worsens the prognosis if cancer is encountered? And is power myosimulation worse than other forms of myosimulation? Remember this was the picture I showed you earlier on? It belongs to a case of unexpected uterine leiomyosarcoma after treatment of 6 months with ulipristal acetate. The patient finally went for surgery because the symptoms did not improve, and contained power myosimulation was done. So power myosimulator, is it a necessary evil? We know that it is a great innovation and help a lot in laparoscopic myomectomy to facilitate and cut short the operating time. However, it is associated with disseminating malignant cells and worsen of prognosis. You may argue that there's no prospective, well-designed data to confirm this, but however, multiple retrospective cohort studies, etc., do support this. It disseminates benign diseases too, as we mentioned earlier, risk of inadvertent injuries to other organs. However, I think this is operator dependent, and disruption of pathology specimen. Because without this, the alternative would be either laparotomy, mini laparotomy, vaginal or colposcopy extraction, or using scalpel or Caesar myosimulation. This is an interesting study published by the Agency for Health Care Research and Quality in 2017, where they look at 24 studies and analyzed 384 leiomyosarcoma. And with statistical modeling, they try to correlate myosimulation method to the 5-year survival rate. And they find that when there's no myosimulation done at all, 5-year survival rate is 60%. When you use scalpel to myosimulate, not much difference. But when power myosimulation is used, it dropped by half to 30%. Of course, all these data provide a feeding frenzy for the lawyers, especially in the United States. This year in February, FDA kind of updates its advisory. It recommends performing contained myosimulation in women when laparoscopic power myosimulation is used. And this position is also adopted by ACOG, AAGL, and Society of Gynecologists Oncologists. So that leaves us with 4 groups of gynecologists. One would perhaps perform laparotomy for all patients that require myomectomy. Another group of patients that would just do as what they have been doing without any change in the practice. That means they'll do myomect, they'll myosimulate everything as usual. Or those that do selective myosimulation only for perhaps the so-called low-risk group for leiomyosarcoma, those that is below 40-year-old or 50-year-old, depend on the threshold. Or another group that will perform morcellation in back for all cases. There are a couple of these containment morcellation bags available in the market, depending on which country you are. So far, pneumolinear from Olympus is the only one that is FDA approved. However, this system, although is smart, but it's probably more designed for single incision laparoscopy because you require a 2.5 centimeter incision to insert the system and to utilize it. With a 2.5 centimeter incision, I think we could do this. Put a fibroid in with the back and use a scalpel morcellation quite effectively and quickly. In Singapore, this is one of my case, patient multiple fibroid. The only bag that is available to us is more safe. I think it's manufactured from India. All right, so this is when the back fibroid is put in a bag, and this is a morcellation. This is the marking of the back. However, the bag is not foolproof. There are unresolved questions about it. It does add more operative time. You may require more pots, bigger pots, more assistance may be needed, and it's not that cheap either. It's not proven to completely prevent malignant cells leakage physically, and there's obviously user's problem as well, inadvertent perforation of the back or spillage. So it is meant for cases, not meant for cases suspicious of malignancy, but only for cases presumed benign. I'd like to end my talk that laparoscopic myomectomy benefits women, but competent surgical expertise is important to ensure good outcome, especially if future fertility is desired. Judicious use of pulse morcellator is justifiable. And I do urge that we should consider contained morcellation, because this may further reduce the risk to patients as well as some medical legal problem to the surgeons. With that, I thank all of you.
Okay, thank you. Thank you, Dr.
Thank you very
Beh.
much.